Since we are striving to really have an interactive conference, I guess you will have to have your phones ready very soon again. First of all, a background to this award. As the conference was approaching, the idea came with our Spanish partners to propose an award recognizing the benefits of implemented innovative practices, producing evidence-based impact on patient safety. And the idea was to create an award recognizing all these good ideas and to see whether we could also have some nominations. We wanted to ensure that by dedicating a day to digitalization and patient safety, we weren't implying that impactful change always requires high-tech solutions. While technology offers tremendous potential, many of you are engaged in projects focused on areas like, for example, hygiene or communication, areas that can see significant improvements without a tech-heavy approach. Our goal with this award was not only to recognize impactful innovations, but also to encourage exchange and mutual learning. This is why we choose to highlight projects not restricted by commercial licenses, whose creators are committed to sharing their practices openly for broader adoption. We named it the Butterfly Impact Award in Patient Safety, inspired by the concept of the butterfly effect. Small actions can create powerful, far-reaching impacts across a larger system. And actually, we received a number of really high-quality projects, among which we had to select only 3 nominees. A committee of patient safety experts was set up to evaluate the projects, consisting of the board of European Patient Safety Foundation and also our advisory board members. As you may have guessed, we made sure that the different perspectives on patient safety were represented, with 2 healthcare professionals, 1 patient organization, and 1 industry representative. And their careful review was based on the following evaluation criteria: level of innovation, evidence-based impact on patient safety, level of involvement of healthcare professionals and/or patients, feasibility and replicability of the practice to other contexts and countries. So, we will now invite the 3 selected projects on stage, and these 3 finalists will be invited to present their projects for a maximum of 5 to 7 minutes. Let's see. And you will decide on the ranking through the interactive voting at the end of this session. So, this is really an honor for me to, first of all, call Professor José Joaquín Mira, who will present the first nominated project. It's called the European Researchers Network Working on Second Victims, and it's the ERNST Consortium Cost Action. Very welcome.
Okay, so it's your turn.
Yeah, good morning, everybody. I'm pleased to introduce Professor José Mira, Chair of ERNST, active member of the Spanish Society for Quality Assurance for many years now, and who loves running at the first time in the morning.
Buenos días, les presento al profesor Reinhard Strametz. Él es vicepresidente del consorcio ERNST, es seguidor del Frankfurt y espera pacientemente que Alemania algún día gane a España. Estamos muy contentos de presentar este trabajo del consorcio que conjuntamente tenemos el honor de dirigir y que es financiado por COS. Y les vamos a presentar qué hemos hecho en estos últimos 4 años y que pensamos que ha tenido un impacto claro en la seguridad del paciente, en la capacidad de resiliencia de los profesionales. Y para eso les vamos a presentar un vídeo muy corto.
Today we are proud to present the work of the European Researchers Network on Second Victims, or ERNST Consortium, under Coast Action 19113. Over the past 4 years, our network has made significant impact on patient safety and healthcare transformation. In the following video, we are presenting our challenges and our key achievements.
Por favor, si puede conectar el vídeo.
The European Consortium for the Study of the Second Victims Phenomenon, ERNST, has led Action 19,113 over the past 4 years. This action, funded by COST, European Cooperation for Science and Technology, aims to improve patient safety by emphasizing that the emotional well-being of healthcare professionals is a prerequisite for quality care. ERNST has extended the concept of the second victim to all professionals in healthcare and social care institutions, addressing a range of traumatic situations they face in their work, such as resuscitations, patients not responding to treatment, lack of resources, care pressure, fatigue, or systemic failures that could lead to human error. These highly stressful and common situations in clinical practice lead to burnout, defensive practices, and disillusionment, which put patients at risk of experiencing adverse events. ERNST integrates a broad multidisciplinary team with researchers from Europe, the United States, Canada, Japan, and Latin America, aiming to strengthen the resilience of professionals to achieve better professional practice and better health outcomes for patients. In the course of its work, it has developed a 5-stage intervention model that includes actions aimed at prevention and self-care, along with peer support intervention for second victims. The research has built on the most successful support experiences and identified the critical factors for the success of these emotional support interventions. Additionally, it has defined by consensus of a large number of professionals from 12 different countries, a total of 11 essential indicators to monitor and improve the implementation of these support programs for second victims. The intervention process, to be effective, must be carried out by peers, professionals who are well acquainted with the work dynamics in the various services and units of healthcare centers and who have experienced being second victims. However, in addition to that experience, they need skills in communication and counseling. In this action, we have identified the competencies, communication skills, interviewing and counseling knowledge, and attitudes that these peers must possess, advancing the training of these professionals essential for support programs. Through this joint and multidisciplinary work, we have generated educational materials, typical situations, podcasts, case studies, and made them available to health systems, institutions, and professionals. More than 2,000 European healthcare professionals have already completed the ERNST online course, available in several languages. ERNST has agreed on an institutional declaration endorsed by 31 countries, describing the impact of the second victim phenomenon on patient safety and the healthcare system itself, which has been presented to the highest authorities of the European Parliament.
Yeah.
Thank you.
So we are not finished. We are not finished. ERNST is committed to patient safety as reflected in this collective statement by 31 countries, which were recently discussed with the European Parliament President Roberta Metsola. And ERNST impact goes beyond a network, it's a movement reshaping patient safety and healthcare culture.
Bueno, hemos procurado que nuestro trabajo no se quede en lo estrictamente conceptual. Hemos intentado ir más allá, comprometidos con la seguridad del paciente, y hemos avanzado en una declaración conjunta de un amplio número de países europeos que hemos podido debatir con la presidenta del Parlamento Europeo recientemente. Es un movimiento que pensamos está transformando la visión sobre la seguridad del paciente, incorporando elementos que hasta ahora no se habían aplicado. Sorry. Y por último, nos complace compartir con todos ustedes que nuestra acción ha sido una de las 6 seleccionadas por COS para el año 2025 y tenemos el propósito de llevar a cabo certificaciones de calidad de los programas de soporte a las segundas víctimas en Europa.
We are proud to announce that ERNST is one of only innovations awarded at Coast Innovators Grant in 2025. So this Coast Innovators Grant will enable us to continue by creating an accreditation system for the second victim programs across Europe. We invite you to celebrate this cross-border achievement with us, working towards safer, high-quality care for all. Thank you very much. Gracias.
Thank you. Okay, thank you so much.
Thank you so much. And we're moving on to the next project. And it's called Eliminating First and Dehydration Before Surgery and Procedural Sedation, that will be presented by Dr. Ann Rüggeberg and Dr. Elke Nickel, both anesthesists at the Department of Anesthesiology and Pain Therapy at the Helios Klinikum, Emil from Behring in Berlin, who have been working with preoperative fasting for 6 years and developed and implemented fasting cards in their hospital. So, very welcome.
Thank you very much. Dear colleagues, dear Chair, thank you very much for the invitation and the opportunity to present our project, Eliminating Thirst and Dehydration Before Surgery and Procedural Sedation. In 2019, the World Health Organization announced the first Patient Safety Day under the claim, "Speak up for patient safety, no one should be harmed while receiving health care." So we anesthetists care for well over more than 300 million operations worldwide per year. And I say we have a lot of safety features, right?
Yes, but don't you think that sometimes we ignore reality?
Yeah, sometimes, maybe. Maybe there is a problem. It shouldn't be, because it's clear. The guideline for preoperative fasting states that it's allowed to drink clear liquids up to 2 hours before surgery. But in real life, we have much longer fasting times. Median fasting times for patients undergoing surgery are 12 hours. So one would say, hey, that's not a big deal if they drink a little bit less, right?
Well, don't you think, did they never heard of dehydration? Some even call dehydration a silent epidemic. And dehydration is a real risk factor for patient safety. Patients who go dehydrated into surgery have a much higher incidence of postoperative complications like respiratory, renal, cardiovascular, or neurological complications than patients who went well hydrated into surgery. And this had something to do with liquid fasting was clearly shown in this study. Patients who hadn't had anything to drink in the last 6 hours before surgery had a more than 10 times higher incidence of postoperative delirium than patients who had something to drink within the last 6 hours.
It should be clear that this could not go on any further. So we took into consideration the risk of aspiration, which is fairly low, against the complications from prolonged liquid fasting, like thirst, like delirium, like renal failure. And we decided to establish a policy of unrestricted drinking before surgery. And as you all know, it's nothing more easy than that. You write an SOP, and then you discuss it with your anesthetist, and you're all set. And we have learned, no, we are not all set. We have a lot more patients and personnel which need to be involved and informed, and even some of them don't speak the local language. So what to do?
Well, therefore, we developed fasting cards. Fasting cards are a 3-level color-coded system. For patients without significant diseases or special features, they get a green card. And with these green cards, patients are allowed to drink clear liquids until they are called for surgery or called for procedural sedation. For patients who need an individual approach, they are given a yellow card, and you can note fasting times for solid and for clears as you need it on these cards. And for critically ill patients who are not allowed to eat or drink anything from the indication onwards, they get a red card.
Inpatients are receiving a reusable fasting card, which is pinned to their bed. And outpatients and pre-admission patients receive the basically same card, but as a paper flyer to take home for information. At the back side of the card, there's space for 4 different languages, and on our homepages, we have already 14 different languages which can be customized by the hospital, and because it's easy and freely available and downloadable from our website, you can customize the cards as you like to.
And you can use the fasting cards concept for all patients in your hospital, before procedures, sedations, like in bronchoscopy, cardiology, or gastroenterology, in anesthesia, and for emergency patients also. And with our easy-to-follow algorithm, every patient in a hospital can be given a fasting card by the nursing staff. For anesthetized patients, the color of the fasting card is noted on the anesthetic record. Patients who have a severe reflux, who cannot lay down in a supine position without regurgitation or without severe coughing attacks, they are given a yellow card, and they need to fast for clear liquids for 2 hours. If a patient is waiting for a gastrointestinal examination, he is also given a yellow card with individual orders. All other patients are given a green card, and they are allowed to drink clear liquids until they are called for surgery or sedation. And in our hospital, well, it's already 99% of our patients, they get a green card of our elective patients. And with this concept fasting cards, we were able to reduce the liquid fasting time from 12 hours to 2.1 hours. And patients who knew they were allowed to drink had a median of 400 ml clear liquids before their procedure. And patients who didn't know they were allowed to drink put themselves at serious risk because they didn't take their morning medication. The concept fasting card is spreading throughout Germany. More than 100 hospitals already join in, also some hospitals in other countries. And all these hospitals follow the World Health Organization slogan, "No one should be harmed in healthcare." They let their patients drink until they are called for surgery or for their examination. And as water ice is clear liquid, just frozen, children get a water ice while waiting for their procedure. Thank you very much for your attention. For more information, please see our website.
Thank you so much. Now the third best scored nomination, it's called Effective Communication and Patient Safety Among Nurses in Perioperative Settings, a best practice implementation project, and that will be presented by Doina, Carmen, Mazilu. I'm very sorry about my how to pronounce it. So, and we also have sorry. You come from the organization of the Order of Nurses, Midwives, and Medical Assistants in Romania. Very welcome, and the floor is yours. Would you like to have a presentation?
Can I have?
Yeah.
I need to sit here. Thank you. Thank you, Mr. President, for your presentation, for our presentation. It's an honor for us to be here with you and try to present a project who developed, and this project, it was firstly like this project in Romania, and is honor for us to be selected among 3 finalists for this award. The context our project is related to the fact that globally, and of course in Romania, most adverse events in hospital are associated with surgery. On the other side, the use of effective communication can lead to a significant reduction of the complication. The question which we started is, are perioperative nurses compliant with evidence-based practice recommendation for effective communication and patient safety? This project uses a GBI methodology with 7 phases, and we have a process with identify the area that need improvement, involve of change agents, assessing the context and readiness for change, assessing practice against evidence-based audit criteria, implementing the best evidence into the practice, reassessing the practice, and sustainability of improvement achievement. With 3 main stages of activity, a baseline audit, an implementation stage, and a follow-up audit. The audit questionnaire included 11 audit criteria related to education, transfer of patient information, briefing and debriefing, timeout, unnecessary activities, and conversation. We have identified 6 barriers to compliance with the best practice: inadequate knowledge and attitude of nurses, high workload and lack of time, specific architectural structure of the hospital, pandemic context, inadequate procedure for surgical safety checklist, and lack of procedures and checklists for the transfer of the patient information. For these barriers, the project team developed and implemented several strategies: educational intervention, management support, leadership, human resources management, reorganization, empowering nurses, and open communication. Also, the procedures for surgical safety checklist was revisited. 2 new checklists and a new procedures was developed. The checklists were integrated in the flow of daily activities, and the nurses were trained to sensitize. One important strategy was developed of 2 standardized structure tools for the transfer of patient information, perioperative and postoperative checklist. They included 3 very important sections for patient safety, patient identification, clinical risk, and preoperative, respectively postoperative status. What did we achieve? A significant improvement of the transfer of patient information in written form from 0% to 100%. An important improvement of the interoperative communication process, and the most improvement of the transfer of patient information in verbal form, but it was also improvement because we started to 0%. We also had the opportunity to publish the project results in GBI Evidence Implementation Journal, a journal with a very good impact factor. Thank you for your attention.
Thank you so much. And now we're getting to the exciting vote. So please use your phones. Let's see if we can get the picture on. Yeah.
We should get the presentation. Just a second. Yeah, it's coming. It's coming.
Yeah, we're waiting for the... Yeah, there it comes. Yeah, so use your vote. Now we should have some exciting music also, and drums. If there is someone who's used to watch the European Song Contest, this is really... I cannot see the number of votes, so I'm not sure how many of you have really used your vote, but it's up there. Yeah, sorry. It was too. Yeah. So we have yeah. But we're more than 100 in here, aren't we? Yeah. So we're still getting there. Maybe there is someone who would like to be neutral here, but yeah. Is this how far we get? So it's enough of votes, I guess. Everybody has had the opportunity to use your vote. 2 participants are still ranking. Okay, 1 still to go. Oh! Okay, so I guess we have reached the end point of this poll, and the winner is the European Researchers Network working on second victims. Please. Can I please ask José and Reinhard, please come forward. And of course, we have prepared for you something that will, we hope that it will both stand on a very visible place in your office. and Mirka will present the first butterfly patient safety award.
Thank you so much, Mirka. Thank you. Thank you. Yes. Thank you so much. Thank you. Thank you. Thank you so much. Thank you.
And of course, we all would like to thank you all for your presentations, the nominees, and you have done a great job, and we hope to be back with the European Patient Safety Award. We do believe that is so encouraging also to recognize good examples from all over Europe. So thank you so much. And I will maybe leave it to Mirka to go on with the program. Thank you so much.